Join us today for the EGP Learning Update episode, where we're going to be talking about all the various changes that have happened in general practice, including the election of our new GPC Chair, winter access funds, prospective access to medical records, and some awesome stuff about how to use MS Teams better in the NHS, and loads of other content. You're not going to want to miss this one. Let's tech enhance your primary care and learning. Hey GP learners, welcome to this episode, and we're back after having a slight hiatus with both myself and Andy being really busy, and we've got some amazing content for you and definitely some huge updates. But how are we getting on there, Andy?
Yeah, I'm pretty good, Gandhi. It's nice to be back having a conversation with you on Saturday morning in our Saturday morning surgery.
Yeah, so as we mentioned, we've been away for a little bit. That's partly because we've had some conference stuff that we've been doing. Do you want to fill us in on how it's been, Andy?
Yeah, so it's been sort of quite busy. I think we've both been quite busy in practice and so forth, but we've also been doing conference work. So I suppose the first thing that happened was the GP 5T2 2021 trainers training conference, which was a really big success. And for those people that missed out on the conference, I'm just going to bring up on screen the link where people can sign up to review some of those videos and conference content that was recorded on the day, that's available now after the fact. Any reflections on that day, Gandhi?
It was an awesome day. We had some really cool content. We had an update by Dr. Shabbat Nabi about the future of GP training, loads of information from various people like Dr. Nigel J.M. talking about the RCA and how to help with that. Details in terms of how to get through the AK, how to help your trainees get through the AKT, debriefs, backing them, supporting them, a really amazing session that I know that you helped out with Mary, talking about neurodiversity in our trainees and stuff. And we even had some bonus content available on the recording. So if you did want to register, feel free to do so. If you attended, you've got free access to all the recordings. Do check your emails because the final email for that's coming out today. If you didn't attend, you can use the link that's come up on screen, or we'll put it in the chat later on for you to have a look in the show notes, so you can register and stuff and get access to all the recordings from the second of our GP5T conference stuff and things. So yeah, definitely have a look at that and things. And coming up shortly, and I do mean shortly, so on the 2nd of December, we've got our next conference, and this is one I'm really happy to do. We've been working on this for about a year, believe it or not, Andy, and it's basically an MS Teams user conference, so to try and help all of you use MS Teams better in general practice, in the NHS, and that kind of stuff. And we've got a massive lineup of stuff, to be honest. We're working with Redmore Health to try and provide the content, so anybody who's come across them, amazing group that just know how to help people learn how to use tech better, kind of do a little bit what we do, but in some ways they do different things, and definitely more focus around supporting the practices and stuff. But we're working with them to provide this content. And yeah, basically, if you don't know how to use MS Teams, you will do by the end of this conference. If you do know how to use it, we will be able to show you how to use it even better. So things like video group consultations, things like how to do MDTs. If you're training, how to use MS Teams for supervision, and GP training and that kind of stuff, as well as what I'm hoping is going to be an awesome keynote by Dr. Masood Nazir, who's going to be talking about what you can actually do with MS Teams, and some really cool stuff of how to improve your inbox size as well. So if you've got to that point that I'm sure many of us have, where your inbox just keeps telling you need to delete stuff, we're going to show you how to make that not a problem for you.
I'm really looking forward to that, because I am deleting emails that I sometimes think I should be keeping, but I just can't because my inbox is overflowing. Gandhi, there was another page that appeared on the EGP Learning website, which, by the way, has undergone a refresh and looks really sharp and clean. I'm very impressed. So there's the shop page, because I know, Gandhi, you did a little bit of art that's become almost viral, I think, the GP iceberg. Just trying to click on one of these to enlarge them. And they're available in these beautiful prints. It's really great, illustrates all that hidden work that the media, that patients don't see, that GPs are doing all the time in the background. And I know a lot of actually practices and individuals have bought some of these to display in their consulting rooms and around the practices. I think they're really nice. I think they make a really nice Christmas gift. So really impressed, and love the refresh of the website, Gandhi. Fantastic.
Thank you, Andy. Yeah, it definitely needed a refresh for the website. The graphic, I've just been blown away as to how wide that went, and how I was having people sending it to me saying, "Have you seen this?" And it's like, Yeah, I made it. But on top of that, just the comments and the positivity around it and stuff has been really encouraging for myself. And definitely a time where, as some people may know, I wasn't too well recently, just with COVID and recovering and stuff. I'm definitely getting back onto the point of being almost about 100% now. And thank you to everybody who's offered their support with that, especially yourself, Andy, because I know you've definitely helped me through a lot of that. But yeah, it was just one of those things that kind of hit my head, and yeah, creativity spokes at times, doesn't it? And this is definitely something I've enjoyed doing, and yeah, hopefully will help a lot.
Fever-driven vision of the GP iceberg.
Well,
Fantastic.
Yeah, and more to come. So Andy's had a couple of sneak peeks at some of the things coming up in the next few weeks for all of you as well. Just needed a little bit of fine tuning, I think, and we'll have even more stuff like this for the practice to help to tackle some of the challenges they've had and some of the positivity as well.
Cool. So big news this week. We have a new chair of the GPC. Farah Jameel has been elected as the new chair of the BMA's General Practice Committee. So that's some of the big news today. So I think that's what we are planning on focusing a large portion of today's episode on. It's time for new starts, isn't it? There's a new person at the helm of the GPC. I'm sure that person will be, I'm sure Farah will be reflecting on what's in her in tray as she enters that role, what plates are spinning, what balls are up in the air for the GPC and the profession. So we can spend some time just sort of thinking what we think those are, what we think the priorities are for the incoming chair of the GPC. Really interested to know what you think the priorities should be for the GPC going forwards and what you would like to see them doing. If you comment, we'll flash your comments up and we'll reflect on them together with the rest of the audience. But first of all, before we talk about a little bit about Farah's background and where she's come from, and then talk about her in tray, I have some questions for you, Gandhi, because I know you once stood to be a representative on the GPC. It's actually an area that I've never really, apart from seeing articles about them and what they're doing, I've not really looked at it in too much detail. I want to ask you some questions about what is the GPC, how many people are on the GPC, how do they get to be on the GPC, what do they do? All sorts of questions just before we go in, and just to frame things for those audience who aren't familiar with the activities of the GPC. Gandhi, what is the GPC?
So the GPC is the negotiating body of the BMA that represents general practice in its contract negotiations with the government, and obviously more recently that's been with the NHS England. It's formed up of various representatives, which are regionally based, generally speaking, although there are some extra reps for other parts. So, for example, the Sessionals Committee have their own reps. I think the military's got their own reps and that kind of stuff, and other areas as well. So, in a sense, structure similar to the RCGP Council in some ways, but definitely a different process and different outcomes and things. And then they have regular meetings to try and decide basically what the negotiating aims and traction for the GP contract is. They are then their oversight is the officer committee, which is led by the chair. And I guess one thing we'd like to say is thank you to Dr. Richard Vaultry for his contributions over the past few years. Obviously, he stepped down a couple of weeks ago, which led to the elections. And also commiserations to Dr. Chandra Kanageti, who lost out to Farah in the election and stuff. That election was done by the GPC representatives. So it was on Thursday, so 3 days ago for those that are watching this secondary. And yeah, the GPC reps voted in Farah, which is groundbreaking stuff, So a couple of things that people may not know about Farah herself. She's now the first female chair of the GPC. I believe she's also the first IMG for the GPC. In terms of international medical graduate that's been voted into that position. So some real groundbreaking diversity stuff, and her career has definitely, I know we're going to talk a little bit in more detail in a second, but amazing, diversity is probably the best way I can describe it. So my head's still not 100% working, but
that's great, Gandhi. I've got some more questions about the GPC. I mean, you may not know the ins and outs of this. So how many people are on the GPC when they meet?
I can't quite remember the number. There's a fair amount of people, to be honest. What I will say is if people want a lot more detail, and definitely hearing from somebody who's far more expert in me in terms of this, then have a look at our stream we did, which is called What is the GPC? And that was by Dr. Katie Bramwell-Stainer, who joined me for that. And if you don't know who Katie is, you need to, simply put. She's an amazing GP who I have unbelievable amount of respect for, and her knowledge of the GPC and GP politics far superior to myself. And in that session, we basically give you the full education you need to know. And if you're thinking, oh, I'm not sure if I want to watch it, for appraisal, all that kind of stuff, just understanding general practice politics, this is a just about 1 hour session that will cover absolutely everything that you need to know about general practice politics and structure and organization and everything. And it is probably one of the best educational things I would say that you can learn about general practice. So much so, I know several VTSs show this to their trainees as they're here to fill in your politics kind of stuff. So it's an amazing education, shall I say.
Awesome. So Gandhi, before we move forwards, I just want to finally understand the connection between like your job in GP, sat in a practice, and the GPC, and what the kind of the connection, the route is between the two of them. So if I'm sat in my GP surgery and you know, I've got something that I want the GPC to talk about or debate, how does that idea get from me to the GPC? Because I might have the answer to the future of general practice, you know.
So I would say your GPC rep is akin to your MP. Okay, they are your representative in terms of looking at the GP contract kind of stuff, and in terms of accessing them, if you can just go to the BMA website, look at the GPC section, you should be able to find your reps because it's based on regions. As I said, there are some extra ones like in terms of sessional committee and that kind of stuff that have a different route, but the whole point of access, just go to the BMA website, look at the GPC. Your GPC rep should also be engaged with your LMCs, and the LMCs is kind of like, as people probably know, local medical committees is your regional kind of contact for, you know, any form of issues with contracts and that kind of stuff. And your GPC rep should have close links with them because they are often part of their local LMC as a representative, engaging in that discussions. They are technically slightly separate things. So LMCs are more for practices by definition rather than individual GPs, but the blend over has massively happened over the past, you know, few decades, to be honest, to the point where they are intertwined. A lot of the stuff that happens at LMC conference feeds in to what the GPC are then asked to do. And we cover that in the stream as well in more detail as well. So if you thought I want something to change, you know, that kind of stuff, find out who your GPC rep is, just go on the website, stick in the details, it'll give you the contact details, and you can contact them. And like I said, it's just like if you had an issue and you want to raise it with your MP, it's probably the closest analogy I can think of.
That's good. And I suppose similar advice would be there if you want to be on the GPC or you want to have an influence in medical politics. It sounds like the route to that is probably via the local LMC, and that's where you can meet current GPC reps and begin to get involved in that part of medicine. So it's really nice just to know that's the direction.
You know, the terms are 3 years typically, and there's an election process, and that's, you know, a process that if you did want to be your next GPC rep, you can absolutely engage with and learn. But I would highly recommend, if you're thinking about that, definitely have engagement with your local LMC first, because that will give you a bit more of an idea into the process and the way that it works and stuff.
Yeah, just while we're talking about GPC rep elections, I think just like to say we're aware that there's been some controversy around recent GPC rep elections in Nottinghamshire LMC, and it's still something that's being sort of investigated and looked into. So we are aware of it, and we are making the choice sort of not to you know, directly comment on that, because there are sort of investigations and inquiries ongoing about that. But it's not that we're blind to that issue. Full stop. So shall we just sort of take a look at Farah Jameel, because she does sound like a very interesting person. She looks quite young. I'm not sure of her actual age, and maybe it would be indiscreet to talk in those terms about her. And would we be making the same comments if she was male? I think we would. I think I would be making the same comments if it was a young man as well. The GPC, Pulse have done a good sort of breakdown of her career. I'm just trying to find it actually. I'm not sure I've got the direct article linked, but it'll be linked in the show notes. But her sort of CV reads as a roadmap, I think, for young people who might want to be on the GPC, to be honest. But involved in medical politics since early in her career, in 2009, on the BMA's Junior Doctors Committee for a period of time, chair of South Thames Regional Junior Doctors Committee, national executive member of the British International Doctors Association. So I think your international medical graduate feelings are probably right there. She's sort of come through the Equality and Inclusion Committee of the BMA, being deputy chair of that. Also been a council member for the Women's Federation. She's done work with the BMA around referral management and GPs rejecting and directing referrals. She's worked in IT and data issues for and with the BMA, led on workload issues within the GPC as a GPC rep. She's been on the executive team of the GPC, and I believe she was the youngest person elected to rep the GPC at the age of 34 in 2017. So simple arithmetic to arrive at her age, I suppose. Yeah.
I believe that would also make her the youngest chair that we've ever had for the GPC as well.
It must do. It must do. So sounds like a really new, fresh person to the role, but with appropriate experience. So she's there. She's going to have a really burgeoning in trade. There's a lot going on in general practice and medical politics at the moment. So I guess we thought it would be fun to have a think about what's in that in tray and what we might do about it, what we see as the priorities at the moment. Really interested to know what viewers out there think are their priorities really, and what they'd like to see Farah focusing on in the next few weeks and months and years.
And I guess definitely top of that list is going to be the indicative ballot for the GPC. So if you have known anything about general practice in the past few weeks, the BMA and the GPC went through a ballot process to find out where the profession feels they need to move forward with some of the challenges that we've been facing. Obviously, a lot of this was in response to the winter pressures funding letter and the aspects of monitoring and outcomes and that kind of stuff that we've covered in previous episodes and things. And as a result of that, the BMA felt that they had to basically find out if the profession wants to strike over it and what that would look like. So here we go. Andy's sharing the kind of the questions that were asked. So just to read out for those that can't see it. There was 5 questions basically. Number 1 was withdrawal from the PCN-DES at the next opt-out period, which is not a breach of contract. So that would be in April. Disengage from the PCN-DES before the next opt-out period, which is a breach of contract, because to leave the PCN-DES before the term is considered a breach. Refusal to comply with the contractual requirements to ensure GPs declare earnings over £150,000 per year. We're going to come back to that one. Refusal to comply with the contractual requirements to provide COVID exemption certificates. And finally, participate in a coordinated and continuous change to your appointment book to affect the quality of the data NHS England are looking to collect. And I think that was very much in response to NHS England's view of how they were going to collect the data to look at the winter access funds and this whole concept of 20%ers that we've talked about previously and various other parts. So those were the 5 questions.
So Gandhi, we all voted on the 14th of November. What was the outcome of the ballot? We
don't know. It is the simple thing. So the outcome was meant to have been published same time as Thursday as the election. That was when the GPC would have had the information, and they've obviously, the GPC themselves have seen it, but there has been the decision not to share that information with the public and with the general practice itself and stuff. We don't know the reason for that, whether it's just they wanted more time to analyze the data, whether it was a political thing, whether it's a strategic thing, don't know. It's not, I think, for us to comment specifically on the rhymes or reason, but it's definitely something we weren't expecting.
Can we speculate? Why do you think? I mean,
right. Well, okay. No, you're right. We can speculate. I guess we don't know is what I'm trying to get at. We don't know why they've done this. I would probably go down the route of it is either they didn't get the information they wanted to hear, or they want to keep it as a negotiating tool. Because that would seem like the most sensible reason not to tell the public. It's because they feel they, or I guess the third one is just simply they need more time because they've obviously had to now create a new officer team. They've got to do other things with the change in chair and stuff, and whether they feel they just need a little bit more time to figure out. What do you think, Andy?
So I think you've elucidated the possibilities quite well. They either have a strong result or a mediocre result, which was what they were wanting or felt was necessary, and they're using it as a negotiating tactic. Although it would be a more powerful negotiating tactic if the public were aware of it. I think I'm not quite sure how it becomes more powerful being private. So I wonder if they've not got the answer they were expecting, and just having sat in some local sort of meetings at Nottinghamshire level organised by the LMC, and just sort of, putting a finger in the air or an elbow in the water to gauge the temperature on some of these questions, I'm not sure that there was kind of cold-faced ground level support for all of these motions. So I'm wondering if they've not got a strong result, and actually publishing it weakens their position. Feels almost a little bit naughty to speculate on these things, doesn't it, Gandhi? But that's my feeling. I'm wondering if that's the position. I think would be interesting.
Possibly. I think there is also the other thing we do need to consider, and I said I'd come back to it, which is one of those things that they asked about has already in some way been resolved. So that was the concept of GPs publishing their earnings over 150,000 in the past couple of days. The NHS England have said that has been paused. So whether that was an action by NHS England to placate the GPC, or to throw a spanner in the works, or just political movement in the first place, don't know. But the decision to publish GP earnings at that level has now been paused to some point in the spring. No exact dates being given. I'm assuming it's going to be April, because that's when the contract variations come into play. But that has been a change. So whether that's also predicated some of the stuff that the GPC were going to do, because actually they have, one of the things they asked about has already happened.
Yeah, I suppose there are a few things that could be framed as potential early victories, I guess, as a result of the GPC and BMA's stance. So one is the delay in the requirement to publish these earnings of GPs over £150,000. And also, I think there's potentially been a softer approach to the implementation of the winter access funding plans in many places than might have been expected by a direct interpretation of the original letter and plans. And local CCGs who are taking perhaps a more understanding approach with GPs are obviously not being lent on by NHS England, and I think that might be considered a victory as well. I also wonder if it's not just about the battles, is it? It's about the war. And at the outset of these sorts of big negotiations, particularly when someone like the government anticipates that there's going to be friction, and they obviously did, because they didn't show the plans to the GPC and they didn't show the plans to the RCGP before they published it. Sometimes you include some things in your position that you can trade away to get the compromise that you originally wanted. And I wonder if some of these things are going to, and always would have been, strategically traded away by the government. But we will see. Oh, you can speculate about these things all the time, can't you? And it's easier when you're not on the GPC and having to directly deal with it. It must be a very, very challenging job. So got to deal with that. If you're the incoming chair of the GPC, how would you deal with that? Would you have a direction change, or gosh, what do you do?
I think it's difficult, isn't it? The profession's in a point of absolute disarray. Let's be honest with it. We know the challenges that are coming our way and the challenges that already exist. Massive workforce issues, massive morale issues in terms of how the profession is feeling, particularly to the sustained media bashing that we've experienced over the past 3 months in particular. And I think many people are feeling that point where they want something to happen. We need change to help general practice keep going. Otherwise, the absolute worry I think many people have is that it's going to collapse. And as we all know, despite what the media may say, if general practice goes, the entire NHS goes, and what does that leave us with? I think go for it.
I was going to ask you another question, because I know you once stood to be on the GPC. So in another alternate reality, in an episode of Disney Plus What If, where Gandhi was on the GPC, or maybe even ascended to,
I feel like I've got Watu standing over my corner right now, looking at me with those stern eyes.
Maybe even ascended to the heights of GPC chair. I would challenge Gandhi in that position, that the general practice is really diverse, isn't it? In its opinions about all sorts of things. And I have seen a real diversity in the attitude towards the winter access funds, for example. And we'll talk about the PCN DES in a minute. And I'm wondering if the ballot results sort of reflects that diversity of opinion. So if you've got, a large number of GPs who actually are going along with the winter access funding and indicate that they are going to, and then you have another group of GPs who are really, really angry and really, really, suffering potentially. Some people are just about managing. Some people are suffering greatly in the current, situation. How do you plot a course forwards? What would you do?
Yeah, I think it's really difficult, and again, we're going to speculate. This is opinion, this by no means fact and stuff. But you and I are both in a really difficult situation. The fact that we are coordinating some of that as our, one of our hats as PCNCDs and things. And like you say, the views are very diverse and different. I would be thinking that the first and foremost, what we need to do is what's best for our patients and what's best for our practices, because that's also what helps our patients. And I think it's trying to deliver what we can. The Winter Access Fund provides additional funding. What is really, really frustrating is the fact we still don't know the terms of those funding. Yes, they said that, here's some funding to provide extra appointments, but all the questions and answers about what happens if we can't make them, what happens in terms of those funding doesn't cover the cost of delivering extra appointments, which has been a key part in terms of the funding. All those aspects, how are we even being measured? What data is being used to understand an increase in additionality of appointments and stuff? None of those questions, as far as I'm aware, at this point, as us going live, have been answered to the point where you and I, who are meant to be coordinating some of this, can understand how to manage that for our practices. Correct me if I'm wrong on that point.
No, you're right. There's still many pending questions, and actually people's engagement is still conditional for a large part on these questions being answered in a way that is acceptable.
I think that shows the dedication of the profession, that despite what certain parts of the media say, general practitioners, practices and their teams are still, despite all these challenges, trying to provide more access, more availability and better care for our patients, given the fact that it still puts a significant pressure and additional stress because we don't know what we're dealing with. And the fact that NHS England haven't commented on that, I think, is something to be noted. And I think the challenge that faces, again, something to be noted. What that means for the GPC in terms of what they do, I think it makes it really challenging for them as well, because like you say, that they've got different opinions now, which is split, because there's definitely a voice within general practice that thinks that the PCN DES is a really powerful and amazing thing. I think there's definitely voices in the profession that feel that the PCN DES is an absolutely horrific thing, and that funding should have gone straight to practices because it would have been dealt with a lot more effectively. And there are going to be lots of voices that are somewhere between those two spectrums.
Oh, it's complicated, isn't it? Yeah, they're in a really difficult position, I think, and I think that general practice is quite a difficult kind of workforce to represent as a union body, because of that diversity of opinion and that sort of single-mindedness that many of our colleagues show, and rightly show in many circumstances. Absolutely. And that we're a confederation of small businesses, really, rather than bodies. In the circumstances of the business is so difficult. Gosh, it's a nightmare to represent us. I do hope that they are able to find and leverage some bargaining power, and that actually they've not found that they have no bargaining power through doing doing this ballot. But fingers crossed. So in tray for Farah. So it's not all about that. This is the current crisis, the most recent one. But there's all sorts of other issues kind of bubbling away. What do you think is the next sort of most important thing? I mean, there's still some bits of the ballot that I guess we've not dug into as much, but what would say she's got to deal with the current crisis around the ballot and the workforce and the winter action plan, or whatever we'll call it. What will be next on your priorities list, Gandhi?
So I guess time-wise, the next one's going to be the prospective access to GP records. So that's due to start in 10 days, according to NHS England. So this is patients having access to their medical records prospectively from that date, universally. It'll be automatically switched on, and patients will have access to the notes. Now, many people probably think that's an amazing idea. That's an awesome idea. And I actually agree. I think it's a really positive idea, because I think, empowering patients to have access to their records is a really positive step in terms of helping their healthcare, giving back some more responsibility and ownership to the patients in terms of accessing their records. I think the reason why it's a massive challenge for the profession is that this is something that they've been told that they will have to do in the space of a month. There's clearly some challenges that come with that in terms of the tech being able to do it. We still don't know how much of the records are being shared, and the reason why that's important, although some patients will probably feel that, well, I should know everything about my records. Actually, there are definitely key situations where that's not the case. So there's issues about third-party sharing of information. Safeguarding is probably a big one, and I know for my practice that's a big challenge. Protecting vulnerable patients with information that's held on their records for their safety, and that not being shared inappropriately is definitely an important thing. There's aspects of some patients not wanting to know stuff about their records, but how do we make sure that happens in the way that they wanted? And although that's a small cohort of things, and just various difficulties and giving a profession in its most challenging state, right before winter, a month to understand how to do this en masse. Ooh.
I think the issue I have is, so like yourself, I actually think this is a really, really positive development if executed correctly and done at the right time.
That's the key thing, isn't it? Yeah.
Because, when patients come and they sit and they listen to our consultations, and there is a statistic out there about how much is retained, but it's not very much, and actually for a patient to be able to go away and read some notes about that consultation and, and a plan written in a way that they can understand so that they can follow through correctly on the bits of the plan that they've, agreed with and agreed to together with their clinician. And it just is really, really powerful. And also the ability to see results of blood tests, monitor their conditions, go forwards. That's going to be a really, really powerful tool. But the training that people have had in terms of who will see a medical record and what a medical record is for and who you are communicating and how you are communicating it has all been focused about communicating with other medical professionals to this point in time. So the way that GPs and most people in the medical profession writing in notes, not necessarily letters, have been trained and write every day is quite brief. There's a lot of jargon, and you need to be familiar with how notes are written in order to really get a grasp of understanding what many colleagues' entries are. And there's a danger that people just get confused if they see those sorts of entries. There's also an issue with the amount of time available to actually write a good notes entry that will be of value for the patient to see. We're still largely dealing with 10-minute appointments. Telephone appointments are going to be 5 minutes, possibly less. And actually being able to write something that is both not harmful to the patient to read in terms of creating confusion or using words that might alarm them around the consideration of cancer diagnoses without necessarily being able to attach a probability to that, for example. And also that is helpful for the patient. It's really, really difficult. I've just got lots of issues with doing it this quickly and without putting any additional resources around making the access to the records more meaningful for them. Yeah.
And there's also that inequality aspect of the fact there are going to be cohorts of patients who will struggle to have access to their medical records through an electronic route. So making it available to some and not everybody else because of infrastructure issues, because of tech issues, all those kind of things, that also plays into parts of this as well. But you're right. I think majority of professionals are worried about the timing and the amount of time that they've been given to do this en masse. And as I said, we have 10 days at this point in time to action this. And I'm pretty sure there's loads of GPs, their teams, that kind of stuff that still have no awareness that this is going to change in 10 days. And that's a big problem for the profession in terms of education, training, and also making sure we're not causing more harm to our patients by doing this in the wrong way.
So yeah, I think people need to talk to their teams. There's all sorts of tools within the medical record systems for labeling entries, for example, that talk about third parties as not appropriate to be visible to the patient and so forth. So there are the tools out there, but you just need to equip your staff with the ability to use the tools appropriately, make the appropriate judgments, and be aware that what they are writing will be seen by patients going forwards from 10 days time. Any prospect for the GPC or the new chair to do anything about this, achieve a last minute concession, that this is a little bit too quickly and buy more time? Well, fingers crossed, but it's probably in the intro, wouldn't it? It'd be a nice early victory and potential olive branch from the government, or maybe something that they can trade away.
Putting this in at a time right before winter when we know that the profession is under massive strain. The government has its own evidence about that because it's just given us £250 million funding to try and tackle some of those pressures. I think that, this is one that is an easy, just delay it a few more months, delay it till the summertime, put in time and appropriate training to help the profession understand this. And I think that both for the profession and more importantly for our patients, we will see a much more positive experience if they did that.
We've seen last minute concessions around data sharing and IT issues in the past. So it's not beyond the realms of possibility for that to happen. Fingers crossed, that would be nice to see. The next thing I'd put in the in tray is clarity around the future of primary care networks. So appearing in GPC motions and ballots is the notion that practices might withdraw from the primary care network, either when it ends or before it ends, by submitting openly dated resignation letters. This talk really rattled the PCN staff that I work with, the additional roles reimbursement scheme staff and other people who are engaged and invested within the primary care network. They were really rattled by it. I can see this as a problem for recruiting into the roles going forwards if the future of this organization isn't, or this way of working is not committed to by the profession and the very people who are involved in it. Why would somebody leave a secure job with an employment history at the local NHS trust? They might be interested in a primary care network role, but if the profession is saying that they might resign from engagement with that, why are they going to come and work for us? So and I think that uncertainty will be, and people will bleed away. People will leave these PCN roles. So I think that uncertainty is difficult to live with. So I think part of the intro would be achieving some sort of agreement or consensus or consistent position about the future of primary care networks, because I think being unclear about it is damaging and helps no one really, apart from potentially being a negotiating chip. But is it worth it? And will it really have that impact on NHS England? So that's what I think should be in the in tray and why it should be there. Any thoughts on that, Gandhi?
I think the PCN DES will clearly be part of the negotiating movement in the next few weeks and months, because at the end of the day, we've got the next level of outcomes that can be looked at. We know about what is obviously the outcomes for the PCN DES and the IIF fund for this particular year. We covered that in our previous streams and stuff. And you're right. I think the profession is not happy with what's being asked of it, because how much of that is achievable, attainable, and various other parts of it. I can definitely understand many of our ARS roles in terms of how they're feeling about a lot of this kind of stuff and the future of it. I think, we may see more practices, like you say, withdraw this time round, because I think they're feeling that actually it's just not going the way it should have done in some places. I think in some areas it's working really well and effectively. I would love to see some more flexibility from NHS England in terms of the way the PCN DES is applied. The ARS roles, for example, not having to be so stringent in some of the boundaries and the banding and stuff that we've got, having a bit more flexibility of how to use that ARS funding more effectively within our own local areas. I think that would be a really big thing. Looking at the admin management side of it, the forgotten thing that has always been mentioned that is just not been considered. And there has been some adjustment with that. There's been the leadership funding and that kind of stuff to help, I think, but recognizing that a lot of the structures that the PCN DESs were shoved into haven't worked as effectively as they could have done, and it's now causing those liabilities and challenges for networks in terms of maintaining their staff and what they look like moving forward. So I think a bit more flexibility needs to happen, rather than just going on the computer says no attitude that we've unfortunately seen for time and time again. That's my view.
So that's interesting. So I think what I'm hearing from you, Gandhi, is a desire to potentially apply some pressure to renegotiate the primary care network DES so that it potentially remains, but with more flexibility in terms of how funds are used and distributed. For example, we were interviewing a network manager yesterday, and we were asking questions about one of the questions, which I thought was a little bit challenging actually, was how would you renegotiate or rewrite parts of the primary care network DES to be more helpful or more effective for general practice? And I think the answer we got was to allow more flexibility to the use of funds to allow funds to be used for staff wages and also estates, which I thought was a very good answer, to be honest. So that's interesting. I think we're not going to resolve it here, are we? And the right answer is different for different people in different parts of the country. But in the in-tray, definitely. What would be another priority for you as an incoming GPC chair?
It's always going to be there, but it's a massive issue as ever. Workload. And I think this is possibly where Farah's strengths hopefully will come into play. She has been, the lead for workload challenges in the, as part of her previous role as GPC officer and stuff. So hopefully that'll lend really strongly into tackling some of the key issues with workload. The fact that GPs are being asked to do absolutely everything and anything, and still the risk sink, shall we say, of everything in terms of the NHS. There's so many things that come to us that, could be dealt with in different ways, should be dealt with in other ways, and shouldn't be coming to general practice in the first place, but they are, because no one else is available to manage it and do it and stuff. And I think, tackling those kind of things would make life so much more effective and sensible for everybody. Stuff like hospital transfer of work, stuff like letters from, GPs, those kind of things are additional things that just don't need to happen. If they didn't happen, would actually improve the access patients have and improve their experience, because then we're able to focus on what we should be doing, which is providing the healthcare.
I hear you. So, Gandhi, one of the comments that I think the first comment on the Pulse article with regards to Farah coming into post was talking about renegotiating the GP contract in the direction of sort of payment for service, rather than hold the contract, do everything that is necessary to meet the needs of this population, regardless of whether the costs go up or down. And that's something that comes up quite often. Do you think there's any prospect of that?
Because I think if the government brings in payment for service for general practice, is guaranteed to not win the next election, which is why they will never do it.
And I think I understand what you're saying. So what would be the consequences for a government of bringing in payment for item of service for general practice?
I think the government knows that if they do that, their budget will be blown, because that's how much workload, that's how much general practice actually manages for them. If they were to actually pay for the amount of work that general practice actually does, it would bankrupt the NHS, because we do that much work. We do 90% of the contacts in the NHS, and yet we have less than 10% of the funding. That's how cost effective general practice is. And I've said it time and time again, and many people have said it time and time again. Imagine if that funding was more balanced to the actual workload we could do. If we can do 90% of the workload in the NHS on under 10% of the budget, what could we do if we actually were funded effectively?
I agree. There's an awful lot of discretionary effort that comes in from GP partners, salaried GPs, and GP locums, and the rest of the workforce that aren't GPs but are very important as well, because of the nature of the contact that the government has with general practice to provide services to meet the reasonable demands of the population, regardless of what those demands are, regardless of what those demands are stoked to be by the government. They've got a really good deal. So it's going to be difficult to negotiate that, although people keep calling for it. I'd be interested to know if anybody can come up with a hybrid solution or something in between, or just an agreement to stop fueling the demands and stick to reasonable demands, not necessarily consumer Amazon just in time medical expectations of patients that aren't matched by levels of funding. But there we go. I feel like a broken record, but
you might think we've said that before, haven't we? But hey, yeah.
But it's in the in-tray for Farah, because she's going to continue to hear that from the profession, and you've got to either do something about it, not do something about it, but you can't ignore it. So yeah, any other anything else in the in-tray for her, do you think, Gandhi?
I think there's something about building back the reputation of the GPC as well. So I think, over the past few months, there's been questions leveled at the GPC as to how effectual and how directed it's been. And, for example, the election coming at this time, raises the question, why did that happen? what was the reason for having to do such a sudden change at that point, which has caused turmoil for the, because we don't know what's now happening at a point where actually we needed a unified general practice. So I think there is something about, the BMA and the GPC rebuilding its reputation with the profession itself, so that it understands and has hopefully a stronger mandate by doing so. Because, the thing about general practice is the one service across the entire of our country that affects every single person. Yeah. Every person has contact with general practice fairly easily, despite what some papers were saying. And I know there's definitely going to be some patients out there that don't feel they've got that experience. But it's a part of, society that touches every person, whether it's adult, child, any other kind of thing. And that's something that's important to remember. And that's why it's so emotive. That's why it's so easy for the media to bash us against it, because it's something that affects everybody. And there's something about that reputation that needs building back, and if it doesn't, we're going to see continued challenges. And my biggest worry is that the profession is going to fall. To be honest, it's still there.
That's an interesting episode, Gandhi. The fall of general practice. What would happen, and how might it come about? An alternate futures episode maybe coming up. With regards to her intro, I was also going to make the point that she doesn't have to be just reactive to what other people put in her intro or what she's inherited. She can put some items in there herself. I think rebuilding confidence in the GPC, rebuilding confidence in the profession, and I would go further and say rebuilding or rebranding the relationship with the public and the patients, and with the government as well. She's a new face. I'm sure it was a very trying time in the last few years, and there might be an opportunity to build some relationships that function differently with key decision makers in NHS England and within the government. There might not, but it's an opportunity to do some relationship building, isn't it? And listening to all parties. As a new person, you've got an opportunity to refresh things. So hopefully there'll be some listening and some building and some proactive actions in the intro as well. Which is a reasonable place to start to end, unless there was anything else that you think should be in Farah's intro.
No, I think she's definitely got a massive intro to deal with as it is. It'd be you see what our EGP learners think as to what other directions the GPC and particularly Farah need to consider. I'm sure that we're going to see changes happen in the next few weeks in terms of what the plans will be, because there has to be. We're about to head into, winter is definitely coming. Let's put it that way, is it not? And it'd be interesting to see how this manifests with all the various impacts and COVID and everything else that's going on as ever. So we shall see.
Yeah, good. So I always feel that we get a little bit pessimistic on these, but anyone potentially a high note, build back the relationships. I mean, as you say, general practice touches everybody. Everybody's got an experience of seeing a GP. It's difficult to say that about anything else in society, apart from maybe schools and education. This is why things like GPs and schools are just such political touch points, and people can construct, negative and positive narratives around that. And maybe the profession can start to reconstruct its own more positive narrative around general practice and use that to the benefit of patients and the benefit of the profession. There we go. That's my effort at being positive.
Definitely worthwhile. As usual, anyway, EGP learners, if you do have any questions or comments, let us know. We're more than happy to try and tackle them. We're going to come back with some more content for you as ever every week and stuff, and we've got some really cool things planned for you. If you do want to join us for the MS Teams conference, highly recommend doing so. You will not regret coming to it. And the quick code for that is bit.ly/MS Teams NHS, all in capitals. And that will get you straight into register for it and things. And we would love to see you there. We've got, as I said, some awesome content coming up for you. And as ever, we've got loads of tips and tools and stuff on the EGP Learning channel for you to have a look at and stuff. If you found this useful episode, definitely leave us a like. It just lets us know you like the kind of content and things. We'll be back in the next couple of weeks to give you even more updates and other kind of information as to what's going on in general practice and digital primary care. And as always, we're here to help tech enhance your primary care and learning. We'll catch you in the next episode. See you later.